This patient has an AHS score of around 53, that is, he has a very severe sleep apnea. I am doing an uvulopalatopharyngoplasty with cobilation and later with a tongue-based reduction with the cobilation at the same sitting. This patient doesn't have much pathology in the nose and sinuses, so we took the palatal and the tongue procedures together. I am starting the uvulopalatopharyngoplasty with the cobilation in the cutting mode. For uvulopalatopharyngoplasty, I use a bond 401 in cobilation, which is equal to the EVAC 70 in cobilator. And it is done under the microscopy guidance. Tongue-based reduction, I prefer to reduce under the guidance of endoscope, 70-degree endoscope. I take out the uvula also, a part of it, and create a newer uvula, which you will get it in the post-operative period, a small uvula. The limit of the excision of the uvula and the soft barrel all depends on the patient and their tonsils. This patient doesn't have a bigger tonsils, so I am not doing any tonsillectomy. If the tonsils are quite bigger, you always combine a tonsillectomy also along with the uvulopalatopharyngoplasty. Use a fluxometallic tube, nasal intubation, so that you get a lot of space, working space inside the oral cavity. Always work slowly with the pulse mode. Never use a longer pulse mode. Always use short pulse mode, and use the cobilation without touching the tissues much. Just create some space between the one electrode and the tissue. Create a plasma so that there will not be much bleeding. This cobilation is a wonderful instrument. Very cost effective when you compare with the cobilator. Sometimes you get a bleeder at the base of the uvula because of the base uvular artery, but you can again coagulate with the same cobilator. One of the advantages of using cobilation for uvulopalatopharyngoplasty and tongue-based reduction is the relatively painless post-operative period. Part of the uvula and the soft palate has been reduced. Creating a new uvula, so extend the little more to create a newer uvula, and to further extend back the palate. That means I transpose the palate little posteriorly by creating an incision at the two corners with the cobilation wand. So the soft palate further recedes backwards. So there is more space in the oropharynx. So the snoring ultimately stops or reduced to a very minimal. The obstruction in the level 2 is taken care of by this procedure, and level 3 will be taken care of by the tongue-based reduction. It's a newer uvula, smaller. So little reducing the anterior pillar also, this reduction all in relation to the patient depends upon the obstructive episodes relating to the size of the oral cavity, thickness of the tissues, everything. And I take loose stitches and approximate the tonsillar fossas or the palatal margins with the 3O vicryl round body. Don't take tight bites, always take loose bites. Otherwise, in the post-operative period, these stitches may get loosened and cut through and come out. So take loose bites, just approximate but loose, never too tight. Yeah, if you make it tight also, so make it little loose, just approximation, loose. And you can make 3 or 4 bites. This is knots. No need for a tighter closure. It's always better to have a loose approximation. Taking knots within the oropharynx is little tough job, but over experience you can do a good job. As you go towards the superior pole, the knot should be more looser. You can use instruments to put the knots, you can use fingers, you can use knot ties. It all depends. You can use various things. Another advantage of this coagulation is you see the relatively bloodless field, hardly any blood loss during this uvulopalatopharyngoplasty. Couple of knots have not been shown, have been edited in the video. The approximation helps in leaving less raw area, thereby less sloughing in the post-operative period and less chance of infection. But sometimes I change the procedures depending on the patient. Sometimes I do translocation palatopharyngoplasty, sometimes extended palatopharyngoplasty, sometimes I combine a lateral pharyngoplasty along with this procedure, sometimes some salpopharyngoplasty along with this procedure. So you have to modify the procedures, add or delete procedures depend upon the patient and everything. But the uvular palatopharyngoplasty is one of the main thing, and all others are just add on or deletion to the main procedures, and with little modification. Zetaplasty is also another modification of the uvular palatopharyngoplasty. But you stick on to the procedure which one you are comfortable, but you can do variate depending on the patients and depending upon the how much obstruction and everything. Even if you don't put stitches, there is no problem, but it's better because less raw area is exposed, less chance of bleeding, less chance of infection, everything. And this is one step as many times I use on the palate. If I don't do an cetaplasty or so, I do an extended incisions on both the corners and extend up to the molar teeth. This causes intense fibrosis, scarring of the palate in the postoperative period, preventing less flabbiness and less vibration, thereby reducing the snoring to a huge level. See, right in a very bloodless field, always done under general anesthesia. Don't go much into the muscles, just the mucosa alone. Just coagulate it so that you produce an intense scarring and fibrosis in the postoperative period. Now the going to the level 3 obstruction, that's a posterior 1/3 of the tongue. So come to the endoscopy sinus surgery position, the patient in the supine position with head and elevated to 30 degrees, and using a 70-degree endoscope, coagulate the base of the tongue, that is the posterior 1/3 of the tongue, from the level of the vallicula, epiglottic level, vallicula, and up to the foramen cetum. Be patient, keep moving, coagulate, coagulate, coagulate. Coagulation is one of the fantastic instruments to reduce the base of the tongue. Initially, you reduce the lingual tonsil, then the follicles, that's the lymphoid follicles, then you can reduce the muscle in the midline. Always use pulse tone so that there will be less bleeding. You can go up to 1 centimeter deep into the muscles with a sideways extension up to 2 centimeters. With the slowly moving the probe from side to side and go up to the vallicula. Always your working should be behind the foramen sacrum. Coagulation is a fantastic tool to reduce the base of the tongue. And these patients are extubated immediate postoperative period because coagulation doesn't produce any tongue edema. So these patients will not get any edema or respiratory distress. So you can extubate the patient and send to the routine ward. I usually send the patients extubate and send to the routine wards after the surgery. And you get a relatively very good bloodless feel. Even sometimes when you go into the muscle, you may get a bleeding, so you can use, just see the bleeding, you can just coagulate it, that's all. Unless laterally 2 centimeter lateral and 2 centimeter depth where you have a lingual artery, otherwise there is no problem at all. You reduce the tissues, and the results of tongue base reduction along with the uvulopalatopharyngoplasty with coagulation are excellent and excellently excellent. See some bleeding because when you go deep into the muscles, you get the bleeding, just coagulate it, coagulate it. All the tissues are reduced and melted, and the coagulation sucks and are taking the suction process.